So I'm really honored and thrilled to present Dr. Perez, Chief of Transplant, here to give us a long-term perspective on what's going on with transplant and the important things. So thank you very much.
Thank you, Dr. Farmer. Well, welcome. I'm going to give sort of a short and long-term perspective. This is going to be a little different than the usual talks that I give, which are full of data, graphs, and slides. This is going to be more of a story. It's going to be somewhat chronological. And this is the theme right here. Thankful, personal, daunting, and hopeful, a transplant story. So I have no financial disclosures, although I have to say, although transplant is the ultimate team sport, truly multidisciplinary, since this is a surgical audience, this will have a strong surgical bias. If I was giving this to the transplant center, it would be a little different. So here's what I'm going to talk about. The P's. Presidents, patients, perspective, and a shameless plug at the end. So this is the first president I'm going to talk about, Betsy Walsh. She's a lawyer. She's very smart. She gave her kidney to her older sister at about the age of many of you medical students, when she was about 25, just finishing law school. It was a time when her family was in great distress, and she became eventually president of UNOS, and I'm going to tell you about that in a minute. And in June, I heard her presidential address, and this was the title of her presidential address. She talked about how she was thankful for the people that were caring for her. It was very personal because they had a real personal touch. The whole idea of, at the age of 25, going from being completely healthy, looking forward to law school, and then having a workup and giving her kidney was very daunting. But she was hopeful that everything would turn out. So the question is, she was president of UNOS. What the heck is UNOS? Who are they? What do they do? Why do we need them? And what impact do they have on our program? Well, I'm going to start a little earlier than when UNOS was created, back at the turn of the century. The second Nobel Prize winner, who was a surgeon, was Alexis Carrel, who developed vascular technique, triangulation of end-to-end anastomosis, something that we used frequently. I used it just yesterday. And he eventually won the Nobel Prize. Some of his early work was actually in transplantation of organs. That led to some human experience, and this was one of the early reports of a series of 9 transplants. Now, what is unusual about this transplant here? You can see the kidney. It's sitting there in the soft tissue. It's actually in the thigh. That's where they put it at that time. They didn't give any immunosuppression. The grafts lasted for less than a week, but the kidney did work for a short period of time and provided some temporary relief. So that was the early experience. Now, this is a day to remember, December 23rd, 1954. And here are the players. Donor and recipient. I bet you can't tell which one's the donor and which one's the recipient. Just look at the expression on their face. That's the recipient right there. So those were identical twins, and at that time they had no dialysis. So this gentleman was doomed to die. His identical twin had an extra kidney. They wanted to make sure he was identical. How did they find out? They did a skin graft. So here is a skin graft with a homologous graft, same species, different individual. It rejects. This is an autograft from the same person, and this is the identical twin. It didn't reject. So that was the basic HLA test at that time. This is the operation. The operation actually is done almost exactly as we do it today. In fact, this operation almost exactly was what we performed yesterday in a situation. This was in a textbook written by a Dr. Chatterjee, one of the only textbooks at the time. This was actually 1979, but it described the operation back in the 50s. So what happened? The gentleman did fine. He did not require any immunosuppression. He went on to have a kidney that lasted almost 10 years. He died of other problems. And his donor, shown here in the London Guardian, just died about 5 years ago at the age of 79. So the problem in those days was everybody didn't have an identical twin, so you needed immunosuppression. And it was very rudimentary at that time. Radiate the graft. There was an anti-metabolite that had been played with, 6-mercaptopurine. Steroids was the basis of immunosuppression. Cross-matching was just in its infancy, so it was not a very good time. The year here is 1967, and what organ do you think was transplanted here? Here's the hint. So, December 1967, Christian Barnard did the first human heart in Cape Town, South Africa. Here's some of his thoughts after postoperatively. Our patient's immediate postoperative response was uneventful. The nasoendotracheal tube was removed on post-op day 1. Mr. Washkansky was now able to talk for the first time. I asked him whether he knew what had happened. He replied, "You promised me a new heart. I assume you kept your promise." So over the next few days, he did fine. It was said the patient was doing absolutely amazing, steadily improved until post-op day 9, when they knew something was wrong. He was lethargic, listless, wanted to be left alone. Essentially, a week later, he was dead of pneumonia. Why is that? Because the only immunosuppression at that time was steroids and local irradiation. And he was over-immunosuppressed and died of an overwhelming infection. So back to our timeline, what's happening here in Davis? Well, in 1968, the medical school was started. And here is our first chairman, Earl Wolfman, talking with young, eager medical students. I'm sure he's using the Socratic method to test their fund of knowledge. 1968, Jack Palmer, not too long after his residency, was the chairman of the Department of Urology. And he and another urologist, Dr. Michael Sullivan, started the first kidney transplant here at UC Davis. And they did their first transplant in 1972. This was, I believe, their 13th or 14th transplant in 1974. And it was a brother to a brother. What was their experience like? Well, they actually told their experience last year in August, more than 40 years after their transplant. I was fortunate enough to be called by the reporter to just get some insight into what was happening, so we chatted for a while, and here's some of the things that they talked about. Joe, the donor, said, "I can't remember too much, but there was no hesitation," which is very common for our donors. "My scar goes all the way around to my back, and they removed a small rib." That's also relevant to a later chapter in our story. "Lenny, I'm just lucky, fortunate my brother said yes, giving me a second life to live so I could see my children grow up and see my grandkids." So obviously a very good outcome. In retrospect, they were probably HLA identical match, although we don't know. So the urology program was going along, 20 or so kidneys a year. They recruited a general surgeon, whose name you've already heard, Dr. Chatterjee, well-trained, nationally known, another president of the Western Association of Transplant Surgeons. You can see how many presidents I mentioned during this talk. And he joined the program, and immediately there was trouble. Here is his manual of transplantation. The foreword was written by my mentor, Dr. John Najarian, University of Minnesota. And the picture I showed earlier was from this. Now, why was there trouble? Well, because there was trouble everywhere. Here is the cadaver deceased donor transplants. You can see 50% survival at 1 year. Living donor was a little bit higher, HLA identical is higher. So 50% survival, that's that time if you're looking at dialysis or death. Patient survival was a little higher, 70%. Well, if you want to read a scary chapter in the history of the Department of Surgery and the institution, you can read about all of this. It's all outlined in the newspapers, Time magazine. Suffice it to say that it was a difficult time. And they were related to outcomes, but when you looked at their outcomes, they actually weren't too far off from these, but there were other issues that probably were at play, that some were somewhat subjective. The problem is they didn't have any real standard to measure by. Who the heck knew what was going on elsewhere? Nobody knew. It was just kind of word of mouth. This was a registry that came out, but it was voluntary. So it was kind of the wild, wild west back then. So forward to 1978, Dr. Blaisdell comes and starts the department. The dean at some point, because of the trouble that was happening, asked him to take over the department, the transplant program. He reluctantly did so, and there was continued investigations, and the program closed in 1981. Shut down. And this is probably the most objective article that I saw, at least it was an editorial, talked about quality control as the underlying issue. There were other issues, but that was what they were talking about. So right around that same time in 1982, here is a case history of a young man, 49-year-old male Pacific Islander, history of myocardial infarction ×2, CABG, progressive cardiomyopathy, not responsive to medical therapy, no options for repeat bypass, referred for cardiac transplant. How did he do? Well, I know very well how he did, because this is my father. Here he is, a few days after his transplant, with, of course, you can see the resemblance. There's my mother. There they are walking. My brother, who is a news reporter, a much better writer than I will ever be. Dr. Farmer noted that. Wrote this article, catchy title, He Left His Heart at Stanford. Here he was, before the transplant, pretty much bedridden. Here he is afterwards, back to our home. I lived on Guam. I grew up on Guam, and there he is, dancing at my sister's wedding. So, why could that be? Well, he was one of the first patients that received cyclosporin at Stanford. He was like number 30 or so in their series. And cyclosporin was a drug, essentially one of the major advances that you could say opened up the field of transplantation. Instead of having a heart transplant die on post-op day 17 because they are pounded with steroids, now we have, for the first time, a more selective immunosuppressant agent. Cyclosporin acts on a cytoplasmic protein, calcineurin. It then acts on inhibiting transcription of IL-2, which is all T helper cells are dependent on. That's a test on the in-service, all calcineurin inhibitors. So this is the precursor to tacrolimus or FK2. So nobody's going to miss that one, right? So that opened up the whole field of transplantation now, and everybody was jumping on the bandwagon. People were opening up transplant programs all over. It wasn't just kidney, it was all kinds of organs. So what were the rules then? Well, there were none. It was the wild, wild west, as I said, but which hospitals could be doing them, who was qualified to take care of them, who would be appropriate candidates, how were organs allocated, how do we know how a center is performing? It sounds like we need some sort of intervention, and indeed, as usually happens, the government intervened. The 1984, the NOTA Act, National Organ Transplant Act, was passed. Essentially, they created a network, federally funded, non-profit to oversee procurement of organs, allocation, transplantation, all those issues that are essentially up for discussion. So the OPTN, or the Organ Procurement and Transplant Network, was the name of the entity. An organization called UNOS started out, it was in the southeastern United States. It started out as a group of centers getting together, creating a database, computerizing it. They called their database UNOS. More people started to work with them. They then became an independent nonprofit organization, and then they applied and received the contract from the government to be this OPTN. And essentially, UNOS has done this ever since for the last 30 years or so, or however long that is. Here it is. UNOS is divided into all these different regions, 11 regions. The goals are here to increase the number of transplants, essentially equity and sharing, outcomes, optimizing, keeping safe, and efficiency. So committees. These are the committees that make up UNOS, and that's where all the work gets done. Specialty people are in these committees making up policy on all the various details of transplantation. And then there's a board of directors who then takes all that policy and makes decisions. And by their bylaws, it was a group that was heterogeneous. So there were 11 regional representatives and then various representatives from OPOs, transplant centers, patients. Here. Whoops. So here it is. This is the board that I actually had the pleasure of working with. You can see it's a group. There's nurses, there's surgeons, there's mother donor, cardiologist, pediatric surgeon, psychiatrist, recipient, OPO, pediatric, and there is even right here a surgical resident. Now let's go back to UC Davis. The kidney program is closed down. There's a lot of scrutiny happening. So what does UC Davis do? They open up the first liver program on the West Coast in 1983. Here is the third president that I'm mentioning, Dr. Dick Ward. He was president of the Association for Academic Surgery. Gifted technician, vascular surgeon, came and started the liver transplant program, first one on the West Coast, and initially did very well. So in 1985, after 4 years, they started the kidney program. It remained with the Department of Surgery, led by Dr. Ward and Steve Bartlett, who some of you may know is actually the chairman of surgery at University of Maryland. And it was a joint community program between UC Davis and Sutter Memorial Hospital. They did well, they played it safer, they made good decisions, they came back. The newspaper was much kinder to them, although you can't really see these pictures, but this is Dr. Bartlett. This is the first patient, had Fabry's, did well with his 3-year-old. Then they even started the first pancreas program in the state. Dr. Bartlett was, that was his interest, and things are going very well until 1991 when both of them decided to leave. So, as I was just finishing my fellowship in 1991, Dr. Blaisdell called me up and said, "Do you want to come to Sacramento?" And I said, "Sure, I'd love to." Well, actually, here's the pancreas that I was talking about. That patient was still alive when I got here. He was glad to be off all them needles. And so in 1991, I came and brought along with me my fellow transplant fellow from Minnesota who followed me. And so here we were, two young fellows straight out of training in this very interesting environment, trying to make heads or tails of the place. Dr. Basadana, he was passionate about the pancreas, and we actually were doing more pancreases back then. And we had an interest in pancreas, and so some of our outcomes were great, and some of our patients, well, I told you I'd talk about patients. Here's Chris Chiarello, who after the pancreas, his kidney pancreas transplant, he ran the 100th Boston Marathon and did very well. Was honored by being one of the torchbearers for the Olympics in Salt Lake City. Here's Royanne Hollins, a paralegal who was legally blind. At the time of her transplant, she had a seeing eye dog, as you can see here in this newspaper article. A year after her transplant, she retired the seeing eye dog because her vision improved, and 2 years later, she actually got a California driving license. So, I don't know how her driving record was, but she was having a grand time. So we were studying here why do they get their eyesight back? Some of them do. And we had a pathologist here, Tony Chung, who had an intravital microscopy, looked at their fundus. It was a sort of a look into their vascular system, and what he found, and we published, was that before the transplant there was leakage and sluggish blood flow. After transplant with normal glycemia, it normalized. So transplant patients can have a normal life and they can get pregnant. I don't know if it's normal to have 3, but that's what she had. She did very well. She was a kidney patient, and her kidney lasted only about 12 years, but her triplets were still doing very well, the last we heard. So, so here we come into the late 90s, and the veterans arrive. Dr. Basadana left, so I was by myself again, and Dr. McVicker arrived in 97, and 2000, Dr. Trotman. These are more recent pictures. They were seasoned at the time, but probably not quite as seasoned as they are now. And we had a shift to living donation at that time. And why living donation? Because it's so much better than deceased donors. The half-life of a living donor is about 18 years, twice that of a deceased donor, and then an HLA identical will go 30 years. So here are our happy pairs, living donation. And at the time, there was a clear disincentive to living donation. This is Oscar Robertson, one of my childhood heroes, sports heroes, Cincinnati Royals basketball player, triple threat. Gave his kidney to his daughter, and he had one of those scars like the other patient talked about, went all the way to the back, 18 inches. Then you remember the name Lloyd Ratner. He was our visiting professor a couple months ago. In 1995, he described the first laparoscopic donor nephrectomy. So this clearly was much gentler, and it enabled the patients to have a quicker recovery. It took away that disincentive and actually contributed to an increase in living donation. We were one of the early adopters of this and built up the largest series on the West Coast for a long time because the other centers didn't start for several years later. So we were able to take advantage of that, and Dr. Trauman here, you can see here, we published one of the early multiple arteries in the laparoscopic donor. We were the first ones to publish the series of laparoscopic donor kidneys to pediatric patients, and then UNOS analysis. Why did we think this was the pediatric situation? Why did we think that was so important? Well, because a lot of times the donor was very active in childcare, and so it really made sense to have a quicker recovery. So, and here is one of our healthy donors, Jason Weckworth, another donor that after his transplant, after his donation to his father, he 3 months later ran the international marathon, and then got an idea, why don't we use cycling as a platform to promote organ donation. So he was the founder of a nonprofit organization called Team Donate Life. Decided that the main event that we would be involved in was the Race Across America, which is a nonstop race from San Diego to Atlantic City. This was our first race. Two celebrities here that you'll see. Dr. Battistella, our late chief of trauma, who many of you have known or heard about. And on the end here, Dr. Eric Heiden. He was our ringer, 5-time Olympic gold medalist that in ice skating, and thighs that were as big as my chest almost. The next year was even more exciting because that year we had not only a donor but 2 transplant recipients. Let's see, Neil Bizarnik is here, a kidney recipient from his father, and Bobby McMullen, who is a legally blind mountain bike racer and athlete extraordinaire. And then another celebrity here, if you can see them right here, our own Professor Dr. Jonathan Pierce. Here's the route. Beautiful scenery in southern Utah. Not so beautiful going up the Rocky Mountains. More beautiful going down. Going through southeastern Ohio, probably my favorite. Somewhat delirious as we get towards the Appalachians. Even more delirious as we get closer to the finish. And then you finish in New Jersey, Atlantic City, and you go to from the Pacific to the Atlantic. It was a very exciting time. It was a very interesting time. It started a movement of more teams. Next year there was an 8-person women's team here from UCD. And then after that it went into more running, but it was a chapter in our history that I remember fondly. So we continue to push living donation, and now as more and more living donors are being done, if you have an incompatible donor, you can do an exchange, or a 3-way exchange, or N is the limit chain. Here was one of the first papers published in New England Journal of Medicine about one of these chains, and here's a picture of our 4-way chain here at UC Davis. So we're getting busier, the old guys are getting tired, and the cavalry is coming. A sight for sore eyes. And now I'm going to talk about the next president and the last president. So this president, in his State of the Union speech, said, "After all, innovation is what America has always been about. Today, the discoveries that are taking place in our federally financed labs and universities could lead to new treatments. Here he was actually talking about treatments for cancer, but later on he talked about treatments for patients on the wait list. He proclaimed April the National Organ Donation Month, and he proclaimed that there will be an organ summit to get innovative minds together. I received an email with this seal on it. Initially, I thought it was a hoax. So I had my secretary look up the name here, and indeed, he was on the White House staff. So I took it seriously, responded, and was invited to the White House. And here it is. We must harness this spirit of hard work and creativity to help shorten the organ waiting list. Hard work and creativity, that means it's time for me to show a picture of one of my kids. Hard at work and creative spirit. This is the reason why we were asked to go, because we were perceived as being innovative and had shown that despite over the last 10 years, the organ transplant rate in the country was flat, ours had actually gone from, you can see here, to last year, in the fiscal year, we did 360. So almost a transplant a day. So I went to the White House. Here I am, after going through the metal detector and having dogs sniff all around me. I was greeted by young White House staff that looked like they were still in high school, and they gave me a box of personally signed chocolate Hershey Kisses from President Obama. Here's my photo op. And they said, you have 3 minutes to tell how your innovation has resulted in this increase in transplants. So what did I talk about? I talked about the 4 Ps, of course. Perspective, plan, process improvement, and possibilities. So this is what I told all the government muckety-mucks. Perspective. Here's the national crisis, and we are dealing with the crisis. It's not like the days in the past where organs were plentiful, but now there are more than 100,000 on the wait list, and the rate of transplant is flat, except for, of course, at UC Davis. So our perspective is this is a crisis. So we're not interested in doing things like we used to. We're looking at everything and trying to develop creative solutions. So the second P is a plan. Looking at the opportunities, and here were the opportunities that we identified. And we tried to look at all of those opportunities. Dr. McVicker earlier in the month talked about our pediatric experience. That was just one of some. Process improvement. You don't just go trying crazy stuff without any thought of outcomes, but you're data-driven. Even though I'm not showing any data on this talk, we are data-driven. Frequent analysis of factors that may contribute to outcomes, M&Ms, looking at CQI, looking at everything. And then once you figure out a way to improve, you incrementally take risks. So these are the areas. We went from donors of 10 to 8 to 6 to 4 to 2, and now we're probably going back up to 4. AKI, 2, 4, 6. Terminal creatinine, now we're actually taking them on dialysis, and they seem to be doing okay. DCD, most people won't look after 60, but we will go up to 120. Cold ischemia time, I'd like to say this was by choice, but this is related mostly to OR access, waiting up to 60 hours. I can talk about this for another hour if you want me to. So where are we? It's actually as busy as we've ever been. Last fiscal year, we did 360. At the end of 6 months of this year, we're on pace to do 440, which is a number that I don't think any other transplant center has done. So this is July, so it may not be 440. It may be 350 if we get tired, who knows? But possibilities, that was the last the last thing. And essentially there is being future-oriented, thinking about what could happen. And so this is where one of my pet projects comes in normothermic perfusion. This is something that we've developed here over the last 4 years, taking cold, injured kidneys, putting them on a warm pump, oxygenating them, feeding them, giving them as much TLC as we can. And hopefully they are re-energized, they're restored, they're rejuvenated, and they are now transplantable. So we, at the last ATC, or American Transplant Congress, we actually had 3 abstracts with this. Sandra here presented an award-winning abstract that she's writing up as a paper. Thank you very much. Yulia here is presented a small animal model. And then for the benefit of Dr. Cantor, we have the Krebs cycle here. We're looking at metabolic changes in these warmly perfused kidneys. So here's the future. We think that really the next paradigm shift is that you're going to have not only transplant centers, not only organ donor hospitals, but organ repaired center. We thought it was a big idea that was worthy of consideration for the UC Davis Big Idea program, but it was actually turned down. But we're still pursuing it because we want to become an organ repair center where we take organs, we fix them, we repair them, we give them TLC, and then we transplant them. So, going back to the first presidential address. General, final perspectives, which I would say would be true of our transplant program or anybody in the room that is involved in healthcare. Remembering Betsy Walsh's 4 words, thankful. Thankful for the opportunity to impact our patients. We have an amazing opportunity to have impact whatever we're doing on our patients. Personal, because personal relationships are most important. Of course, I'm not talking about a home setting or the church setting, but at work, at least, patients and colleagues, those relationships are to be cherished. Daunting, she was daunted because of the healthcare system. We have daunting tasks to achieve, and the responsibility that we have is significant. We hear about it every week at M&M. Our decisions and actions have consequences. Sometimes those are life and death consequences. And then hopeful, because the future is hopeful if we have the appropriate vision and support, and hopefully our strategic planning will bear that out for the institution. And then I'll finish off with my shameless plug, which is related to transplant. We think that we have a unique opportunity as an institution to serve the Central Valley and beyond. There is no other transplant in the Central Valley, and we don't think it's appropriate for any patient here to go to the Bay Area or Los Angeles for any of their transplant needs. I would propose that if we can do 400 plus kidneys in a year, we can have a viable thoracic and abdominal transplant program that would serve all the needs and meet the clinical, educational, and research missions of our institution. And then, of course, for the kidney program, maintaining growth and excellent outcome requires resources. Resources are scarce, but once you've achieved a certain level, it's harder to stay at that level than to get there, as evidenced by the early history of our program. So thank you for your attention. I want to acknowledge all of the assistance and the collaboration from all the people at the Transplant Center. There are many people that I left out, our nephrologists, our coordinators, the OR, the nurses, and then lastly, I'd like to acknowledge my family, who's been very supportive this time, and 2 of which are in the audience. Thank you.
first want to say that that was a completely spectacular story. I think if each and every one of us strives to be as dedicated and caring physician as you are, we'll be in very good hands.
Thank you. Thank you.
We have time for some questions.
Dr. Goodnight.
I was a credible witness to this entire history of Dr. Perez relates. He perfectly understated the turmoil when he came in 1991 and superbly stuff got his 25th year. The program was in complete turmoil and had been up and down over the time he presented. What he and Dr. Lustau were faced with was trying to build this thing, watching this problems with the organ procurement agency, organs, political turmoil across the nation about the transplant system. Time and again, works up all night trying to do things. Just an unbelievably never fatiguing advocate of the program. So that what John McVicker and there's no problem. Rick said it's just unbelievable watching this thing come together. In any given year, we're either the second or third largest brain transplant program in the country. My hope to take over first, as he said. So watching this stability come forward, he understated the contributions that he and his colleagues have made to extending the number of donors, extending the life of the donated kidney before he transplanted and so forth. I watched him as a young guy come and take over this tumultuous program and become, with this program, a national leader in this country. It's an unbelievable achievement. Congratulations. And I might say the other thing is physical, is he would have trouble the rest of his life. Someone not put on the donor list and so forth. Next time we've got a gun for us and watch and make sure we don't have assassinated.
My only comment would be sometimes it's good to be young and not really know what the issues are.
No, I think the challenges, the constant OR challenges, the constant work that your team has had to do to make this incredibly multidisciplinary effort come together is just astounding.
Greg, I wanted to congratulate you for your demonstration of this just driving excellence, and this is what our department should be all about. Clinical, research, education, triple threat. That is not easy. And I'm an old transplant surgeon myself, and I know what you've done takes an extraordinary amount of dedication. It's really and truly inspiring. My question specifically is that you mentioned at the end about your big idea about a transplant center, and I totally would endorse the idea of moving towards thoracic organ transplantation, since we're having new recruits that are coming in that are going to have experience in that. But I was just wondering if you could maybe help us with the idea of what it takes nowadays to regenerate a program now that UNOS is there, and is it, again, we already have, are there regional exclusions? For example, I found it particularly galling when I came here to have Sutter down the road doing heart transplants at 10 or 12 a year, and when we are the transplant center seem to have the infrastructure to do that, I would think that we should and will be able to do it better. I just wondering if you could comment what it would take to get a transplant program going in Nebraska.
Well, it's much more regulated now. So there are specific requirements for a hospital and each of the physicians involved. It's regulated and very detailed. The plus, though, is that we have so much of the infrastructure here already. I mean, you can't underestimate what it takes to have a program in any organ. But once you have one that's functioning, then it's a lot easier to get the others going. The other thing that's changing is that there's been a move towards broader sharing of organs, because organs are now being considered a national resource. So before, when we had our programs, we only had access to our local organs. Now it's much more broad sharing. That's one of the reasons our kidney program has grown, because we have access to broader sharing. So it can be done. It's just you have to find the right team. You have to have the support. You have to have everything. I mean, people know how to do it. People have done it elsewhere. And I know that people would be very willing to come here because they see what we can do with with kidney, and they know what, just the having an operating room that can actually process, 400 kidneys a year. I mean, that's not to be taken lightly. The ICUs, the same thing. I mean, the way that people work together here to take care of sick patients, that's what we're good at. So it makes absolutely no sense not to have a thoracic and a liver program again. I mean, we could do it better than a lot of places that don't have what we have, and yet because they have the institutional commitment from the top, they can get it done in a much lesser environment than us. So it takes, like I said, vision and support. So my question to the institution is, what's the vision? And that's being decided.
So this is the time right now. I think we have talked, Rick and I have talked, others have talked about redeveloping our liver transplant program and starting a thoracic cardiac lung heart transplant program. Right now, this week, this month, is when our dean is thinking about these things, putting it together. She just sent out a review of some of the last retreat stuff, which, we are not retreaters in general. Surgeons, we've got lots of other things to do. But this is the time to send an email to her, to send messages and say, you can talk about this grand rounds. We were the leaders in this. We're on the precipice of making these changes. We need to do this for our region. And now is the time to voice that opinion and get it out there, because I agree. We should be doing it. That's our moral obligation to this part of the state that really is underserved relative to our brethren on the coasts. And we are the only place we really are truly the only academic medical center that represents inland California. And we should do this. We owe it to this great legacy and the work that's been done here. Thank you again.
Thank you.